Okay, hello everybody and welcome to the webinar today. This is a series of webinars produced by the Cracks in the Ice team. And in case you haven't seen Cracks in the Ice, I'd encourage you all to log on to www.cracksintheice.org.au to have a look at an online community toolkit providing trusted and evidence-based information around the drug crystal methamphetamine or ice. And it includes information about staying safe, getting the facts about ice, and links to resources and support if needed. We also have tailored resources for grassroots community groups, schools, health professionals, and families and friends with loved ones using the drug ice. We'd always also welcome any feedback or comments that you have on the site and also on the webinar today, or any suggested topics for upcoming webinars. So please feel free to get in touch either via the website or to contact me. My name is Louise Burrell. I'm a postdoctoral research fellow and project manager of the Cracks in the Ice online toolkit. And it's my absolute pleasure today to introduce to you Nicole Lee. We're extremely lucky to have Nicole with us today to take us through what I think will be a really exciting session. So Nicole is Adjunct Associate Professor at the National Drug and Research Institute and also Director at 360 Edge, a specialist consultancy for the alcohol and other drug sector. And her focus is on the translation of research into practice and policy with an interest in methamphetamine practice and policy responses in comorbidity treatment. She's worked in the alcohol and other drugs sector for 25 years as a clinician, academic, educator, and service manager. She's also a practicing clinical psychologist and national president of the Australian Association for Cognitive and Behavioural Therapy. So it'll be a great session today. I'll hand over to Nicole in a minute. I'd also encourage you, as Nicole's talking, if you have any questions, there is the option to type in questions through a question bar on your panel. So please send those through to me as we're going, and I'll collect those and we can have a bit of a discussion at the end, and we'll also open it up for more questions or comments at the end. So without any further ado, it's my absolute pleasure to hand over to Nicole to take us through the rest of the presentation. Thanks, Nicole.
Thanks, Louise, and thanks for inviting me to present this webinar. I'm going to be talking about the effects of ice on the brain and the body, and a little bit about what to do, not so much about treatment, but more about the broad implications of those effects on the from using methamphetamine. Sorry. All right, so you've probably seen these types of images floating around the internet. The human versions are often referred to as the faces of meth, and they really speak to some of the perceptions about the physical and cognitive effects of ice on the people who use it. There are some significant effects of methamphetamine, but in reality, very few people who use meth end up looking like those images. And these types of stereotypes, I think they're not only very stigmatizing, but they don't actually help us in a practice sense to understand the nuance of the effects of methamphetamine, and also doesn't help the people who use it to understand where the harms are and some of the effects that they may be experiencing, and try to make sense of those. So it's a really good idea if you're in policy or practice to get really familiar with the types of effects that meth can have, so that we can explain those, do a bit of psychoeducation around those effects with people who use it if they need it. And then that obviously leads on to harm reduction and treatment options. And as I said, I'm not going to be specifically talking about that today, but we will touch on some of that. So just so we're all on the same page, this webinar series is called Cracks in the Ice, but really ice is just one form of methamphetamine. And methamphetamine is one form of a group of drugs called amphetamines. And meth comes in three main forms. It comes in a whole bunch of other forms as well, but mainly we would see on the street speed, which is the powder form, base, which is the kind of paste, and ice, which is the crystal form. Now, I'm showing you this because they're all the same drug. They all have the same effects. They just vary in purity and potency, and obviously appearance as well. So if you take enough speed, you will get the same effects of ice. So I'm actually going to not be talking particularly about ice. I'm going to be referring mostly to methamphetamine because there's nothing particularly different about the effects of ice except the extent of them. So it's a little bit like, I think of it a little bit like if you take an alcohol analogy, speed is kind of like light beer and ice is kind of like vodka. You need to drink a lot more light beer to get the same effects of vodka, but they're both alcohol. They're made differently and they look different and they taste different, but they have similar effects. And it's the same with speed, base and ice as well. And what we've seen, you've probably seen this before, but what we've seen over the last 10, 15 years is a slowly reducing number of people who say that they prefer to use the form of speed, powdered form, and an increase in the number of people who say they prefer to use ice. And that means that those effects then of methamphetamine, what we see as the effects of methamphetamine are amplified because they're using a much more pure form and a much more potent form of the drug. So that's just to keep in mind as we go along. One of the important things to remember when we're talking about people who use methamphetamine is that by far the majority of them, so about 70% of them, use fairly irregularly. They use less than once a month, so that's less than 12 times a year. They're not going to be dependent. They're not going to look like the faces of meth ever, but they may have some mild health issues and at risk of acute harms that are associated with the effects of meth. So let's just talk a little bit about some of those immediate effects that we see in methamphetamine. So I kind of think of the effects as from on a continuum, of course, but around mild intoxication to moderate intoxication to toxicity, which we would call overdose. I'm going to talk about those three things. And I've just got a little video now, which I'm hoping is going to work, of some people speaking about what it's like to be on methamphetamine. And this has come from an ABC series called You Can't Ask That. If you haven't seen it, go watch it. It's brilliant. The whole series is brilliant. But there was a special on ice earlier this year.
What does taking ice feel like? Wow, just euphoria, like absolute euphoria. I know it's a bit stuck when you feel like they're on ice straight away, and then it starts sweating.
Take it, and your heart starts racing.
You kick in the back of the throat, a big rush, and you're strong and send man, you got the energy, you're up and go if you're feeling down.
Powerful, confident, horny, definitely.
You just want to dance, you don't want to go home. Like at 4 o'clock, the lights turn on, the security goes going home. I'm like, no one's staying here for the next 5 hours. I feel like I've got all this energy, I need to go do something with it. So I just sit there and play Call of Duty. But I played it for 24 hours straight. My sister went to her partner's house and I started playing, and then she came home. And it was the next day, and she was like, "Oh, you're playing again?" I was like, "Oh, yeah, again, sure."
Oh, the come down off, it's terrible.
It scatters you. It's scatters you.
You only stay that high for a very short time. You either keep up and keep doing it, or you face the downfall, which is not fun. You try to outrun the come down. You didn't want to have the come down, so you just keep swinging ice. When I was off, I was depressed. I didn't see no future with myself. Just thought ice was just it. You don't think you can survive without it. I should get that helped, I suppose you could say.
So you can see that at these kind of low doses that they're talking about effects like euphoria and well-being and energy and attention, alertness and memory is really good, and sex drive's good. So most of these effects at mild intoxication or low doses are very, very pleasant and obviously what people are looking for when they take it. But you also saw at the end of that they were talking about the come down, and it's the the saying, what goes up must come down. So you get a really great high from it, but also the come down or the crash is quite significant as well. So I've got another little video from the same series, and this time it's some people talking about some of the moderate intoxication effects, which you'll see are less pleasant.
You're not sleeping, your mind zones off in different directions. You might focus on one thing for a long period of time.
You just have your space getting going, you know, space getting.
You transfix on stuff. And people get really bad paranoia.
You do see things, you do hear things. Just thought people were after me. There's nothing after me, it's just all in my head. I got hit by a car, so I was running up Wellington Street, with a bag over my head. Yeah, funny. I was going through paranoia for 3 days. I was thinking people were there that weren't there. Yeah.
So first we were talking about if you take a little bit, and now this is if you take a little bit too much. You start to get some of those quite negative effects that we'll talk a little bit more about in a minute. But particularly people tend to get very agitated. They may have some psychotic symptoms. They may have some other kind of physical effects like nausea and vomiting and headaches. So then if you take a lot too much, then you might end up in an overdose situation. And so we start to see things, particularly one of the biggest physical effects of meth is on the cardiovascular system. So particularly see people with heart problems and increased heart rate and blood pressure, but they may have severe chest pain or arrhythmia or even heart attack and sometimes stroke. And then there's a whole range of other things that you can see on your screen there. If you see any of those things in someone who is using methamphetamine, that is overdose, and that's a medical emergency, and you need to call an ambulance or some medical assistance. All right, the other thing I wanted to flag was that people who use methamphetamine also have a tendency to use a whole range of other drugs as well. So although this isn't particularly about the effects of methamphetamine, when you combine drugs, you increase the harm significantly because you potentially increase the effects of one or both drugs. All those drugs have interaction effects. So you can see from this graph, the red is people who use methamphetamine and the blue columns are the general population. And you can see for all drugs, the rate of use of other drugs among meth users is about 10 times that in the general population. So they really, this group of people tend to use a whole range of other drugs, and that can be very dangerous. And here's why. And there's particular drugs that are commonly used with methamphetamine and are particularly dangerous when that happens. So for drugs like, for example, the sedating drugs like alcohol, cannabis, heroin, and benzodiazepines, if you're using those in conjunction with meth, they can mask an impending overdose because the meth still makes you feel like you're up and awake, but at the same time, the CNS depressant is having its effect behind the scenes as well. So just as an example to make that a bit clearer, a lethal dose of alcohol, as most of you probably know, is about 4 grams of alcohol per 100 mils of blood. So in a blood alcohol concentration, if you blew into a breathalyzer, you would blow somewhere around 0.4 BAC. And that doesn't change in the presence of methamphetamine. But if you take meth and alcohol together, you won't feel as drunk. So you won't have that natural kind of stop on drinking that you might have if you hadn't been taking meth at the same time. Obviously, other stimulants can amplify the effects of meth, but it amplifies the negative effects as well as the positive effects. So if you're heading for overdose, it can amplify that effect as well. And MDMA, particularly as another stimulant, particularly works on the serotonin system and increases serotonin, and we're going to talk a little bit about the brain in a second. But some of the SSRI antidepressants as well make more serotonin available. Meth also does that, and so that can risk increasing levels of serotonin to a dangerous level and result in what's called serotonin syndrome. So people get a bit overheated and then they can overdose, and that's the most common way that people overdose from ecstasy or MDMA. All right, so that means, all of this means that for people who are using, it doesn't matter whether they are using over a long period of time, that they're at risk of some quite significant harms related to the physical effects of meth, and harm reduction is absolutely critical for this group. They're using a lot of other drugs with meth. The effects of meth itself are quite significant, especially if you accidentally take too much of it. All right, so let's just shift a little bit and look at the effects of longer term use. So when I say longer term use, even as short a period as about 6 to 12 months of regular use, not even daily use, so 2 or 3 times a week, you can start to see some of these effects, which seem to come on fairly quickly for people who use meth. So after using for a regular period of time, these are the kinds of things that people start to see as a result of their meth use, particularly kidney problems, because methamphetamine is metabolized through the kidneys, so it puts a lot of pressure on the kidneys. You've probably seen some of the teeth and skin issues, which I'll talk about a little bit more in a sec. But very often, people have sleeping problems and enduring mental health problems, and I will show you why very shortly. And if you've ever seen anyone in treatment who uses meth, they're often very thin because meth, you don't feel like eating while you're on it, and so they often lose a lot of weight to sometimes quite dangerous levels. So one of the really well-known effects of methamphetamine is in the mouth area, and it's often referred to as meth mouth, which even sounds horrible, doesn't it? So what happens is that methamphetamine has direct caustic effects on the teeth, but it also increases the risk of teeth grinding and jaw clenching because of the physical effects, which is called bruxism. But also what happens is that if people aren't eating because they don't feel like eating while they're on meth, it can reduce the saliva in the mouth, and also the direct effects of methamphetamine, like most other drugs, reduces saliva in the mouth. And so saliva is the thing that washes out and is a natural cleaner for our teeth. And if that's not happening, then you're much more likely to get decay and caries. And also, if you're kind of busy doing things and you don't feel like eating and you're maybe not looking after yourself, you might not remembering to brush your teeth twice a day for 2 minutes, and there may be some poor oral hygiene, and then a much higher rate of gum disease and then dental problems as a result of that as well. So that's why people who use meth their teeth can look not that great, lots of holes, a bit brown. It doesn't happen to everyone. In fact, it doesn't happen to most people. But if you're using over a longer period of time, that's certainly one of the effects and the risks. The other thing that people are often really interested in is this skin picking idea. And to be honest, in all the time that I've been treating people who use alcohol and other drugs, and particularly methamphetamine, I've probably only seen 2 or 3 people that looked anything like the faces of meth with all the scabs and stuff all over their skin. So it doesn't happen frequently. It's not a common effect, but for people who are using over a long period of time and they're using a high dose, there's a potential for skin problems. And there's three main reasons for that. The first common reason is essentially a psychotic issue. So they feel like there is bugs under the skin. It's called formication. And it's essentially a tactile hallucination accompanied by a delusion that sensation is caused by bugs, and people start to try and pick them out. The second thing is that meth actually does have some body effects on the skin. So it raises body temperature, it increases perspiration, and it restricts blood flow to the surface of the skin, which can make the skin kind of itchy or irritated, and then people can kind of scratch it, and then they'll get scratches on them, and then they might start picking at those scratches. And the other thing, the third reason, is that meth increases obsessive compulsive type behaviours. So if you've got something on your skin, maybe you've got a little scratch or a mark or something, you might start to kind of dig that out and make scabs on your skin that way as well. But remember that isn't a particularly common effect of meth, but it does happen, and when it happens, they can get infected and all sorts of other things. All right. The last thing I just wanted to talk about before we talk a little bit about the brain is sleep and nutrition. Methamphetamine clearly affects sleep. It's an upper, and it can keep people awake for sometimes 24, 48 hours without feeling like they need sleep, and they tend not to eat as well. So in terms of harm reduction, we do try and get people to at least rest if they're using and they can't sleep. Rest is nearly as good as sleep if you are on meth, and get them to eat something if they can. Even if it's like a banana or a milkshake or just anything light, something nutritious. All right, so let's just put the physical effects to one side for the moment and talk a little bit about the brain effects, and I'll talk a little bit about some of the mental health problems that are related to those brain effects. So methamphetamine has a hugely complex action in the brain. It affects multiple systems in different ways and in multiple ways. And so it's probably one of the reasons why we haven't been able to find a pharmacotherapy that is effective for people who use methamphetamine or who are dependent on meth, because it affects so many different systems. Just one agent is probably not going to be of assistance. But the three main effects of methamphetamine are through these three neurochemicals in the brain. So the first one that I talk about is serotonin, and serotonin has a whole range of effects, as you can see here, but particularly it affects optimism and mood. And it's the thing, as I said, that is increased when people take ecstasy. And that's why people, when they're on ecstasy, everybody's beautiful and I love you and you're fantastic, because they're very, very optimistic and their mood is very good. And meth also increases serotonin a little, not as much as MDMA or ecstasy. The second neurochemical is noradrenaline, and noradrenaline activates it affects alertness and concentration and energy, but particularly it activates our fight or flight system. So when you're taking meth and your noradrenaline levels are raised, effectively your fight or flight system is switched on permanently, not permanently, but it's switched on while you're using meth. So that's why we see increases in aggression in people who use methamphetamine, because their threat sensitivity is very high. They're already switched on, ready and waiting for something terrible to happen. And so it only takes them a little bit to tip over into the fight or flight mode. But the main impact of methamphetamine is on the dopamine system. We can't measure any of these neurochemicals directly, but they do measure markers of levels of dopamine in the brain, and some of the estimates are around 1200% on baseline levels. So that is a lot more dopamine than we would currently be walking around with. So dopamine is the thing that is the neurochemical that is our pleasure signal. So anytime we do something nice, eat a nice meal, watch a sunset, hang out with friends, sex, drugs, rock and roll, we get a little burst of dopamine, and it also acts as a reward system. So we get this burst of dopamine and it tells our brain to do it again. I like that, let's do that activity again. So huge amounts of dopamine are released when someone's taking meth. Now, I've just got a little animation that I'll show you to demonstrate that. So those little blue things represent dopamine. They don't really look like that. And this is in between a synapse in the brain. So normally we do something nice, a little burst of dopamine gets released, sends a message to say, that was nice. Remind us to do that again. Some of those blue things get eaten up in the synapse by enzymes, and the rest get sent back to where they came from to be recycled again. But when someone is using meth, loads and loads and loads of dopamine get released, which makes them feel fantastic. And the methamphetamine itself, that's those yellow things, blocks the reuptake of the dopamine. And so you kind of empty out your whole bucket of dopamine all at once, and then it can't replenish itself. Now that is fine if you're just using every now and then. So you might use on a Friday or Saturday night, and then you might have a bit of a crash period, and then for a couple of days you'll feel really quite flat while your dopamine levels are getting back to normal. So our brain continually develops dopamine. If we dump out the whole bucket all at once, it takes a few days for it to replenish, to fill up the bucket. So if you're just doing that every now and then, not too bad. But if you're doing it every couple of days or 2 or 3 times a week, you empty out your bucket, but you don't give your brain enough time to replenish the dopamine. So it's never at full steam while you're using. And eventually you're dumping out a full bucket, and then it only half fills before you're dumping out that, and then that only quarter fills. And so eventually you actually run out of dopamine. And if there's no dopamine around, the brain does really interesting things and just shuts everything down. Says, oh, I don't need these anymore. I'm just going to shut down all these transporters that can use dopamine, and I'm just going to get rid of them. And so then it even makes it more difficult to produce dopamine and to release it into the brain. And so it kind of cycles in on itself. All right, now just a little bit more about the brain. This is the brain, which is fairly obvious. The red bit is the prefrontal cortex across the front here, and the green bit is the occipital lobe at the back there, just to orient you. And the frontal lobe, or particularly the prefrontal cortex, is the kind of new part of our brain, and it's the part of the brain that helps us with thinking and planning and decision making and all of those higher order thinking processes that make us human. The other important part of the brain that is affected by meth is the limbic system, and that is concerned with social and emotional and memory generation and storage. So these two areas, they need dopamine to be effective, but they also, one of the key things about these two parts of the brain is that they need to talk to each other all the time. So, for example, something might jump out at you in a dark alley, and your limbic system will go, holy shit, what is that? And the frontal lobe will say, don't worry, it's just a cat, calm down. And so that is how we regulate our emotions. But when you've got meth on board, it changes those two systems. So you can see here that these branches are where the dopamine systems run, and they run right through the prefrontal cortex and the frontal lobe and the limbic system. So they need dopamine, those two areas need dopamine to run efficiently and to talk to each other. So when you don't have any dopamine anymore because you've emptied out your bucket so many times that you're not producing any more dopamine, or you're not being able to fill up the bucket anymore, those systems stop working effectively. So both social and emotional and memory is affected, and that's why we get a lot of emotional dysregulation, and prefrontal cortex activity is also affected, and that's why we get problems with planning and decision making and goal setting and all of that kind of stuff. So the kinds of things that we might see are problems with concentration, memory, planning, decision-making, emotion regulation, impulse control. Mood might not be very good because there's no dopamine to make us feel good. And as I said, threat sensitivity can be raised as well because of the noradrenaline effects. So what does this look like with someone in front of you? In terms of actual functioning, what we're talking about is things that do make it difficult to engage in treatment and to stay in treatment. So things like even just getting to appointments. If you think about getting to an appointment, you need to remember it's on. Even if you don't remember it's on, you need to remember to look in your diary to see what you've got that day. You need to know how to get there and to be able to navigate. And these are all prefrontal cortex activities that govern those kinds of behaviours. So you will find that people have trouble getting to appointments. They might be late, or they might forget, or they might come on the wrong day. They might have trouble completing tasks or taking on new information easily, and you may need to be putting a whole range of scaffolding around treatment, more so than usual for someone who's using drugs. Now, one of the issues with these brain dysfunction is that the impairments are actually quite significant. They're larger than we think, than any other drug that we know of. So it's about 20 times that of its nearest cousin, cocaine, and about 4 times the effects on the brain as marijuana, and even 6 times the effects of Alzheimer's disease, although the difference with Alzheimer's is that that is permanent, but we think that the effects on the brain from methamphetamine and of other drugs is relatively temporary. But we do know that even 6 months after someone stops using, their cognition is actually worse than people who are still using. So you can imagine a situation, you go into treatment, you get off methamphetamine, but for 6 months you're actually starting to feel worse than you were when you were on it. So it doesn't give a lot of motivation and incentive to stay off the drug. And we don't think that there's any significant improvement, at least in the first 9 to 12 months. And we say 9 to 12 months because the neuropsych studies have only measured up to 12 months post, but in my clinical experience it can be 18 to 24 months before people are saying that they can think straight again and their memory's back to normal. They're able to plan and think well again, and then their head's not. Often what they say is that they feel fuzzy in the head. So as a direct result of that, what we see is that the relapse rate among people who use methamphetamine is quite high, much higher than for other drugs. And that means we need to put some, again, scaffolding in place around them post-treatment so that we can help prevent relapse, because it's not particularly because those people are not motivated. It's more because of the direct effects of the methamphetamine on the brain. So this is a graph from a study that was led by Rebecca McKeaton that I was involved with, and you can see here at 3 months the people who went to residential rehab who are using methamphetamine are doing quite well. The relapse rate is less than 50% compared to people who didn't go into treatment. So this is the controls. At 1 year, this is around 80%, 78%. So you can see that the relapse rate after a year is pretty high, and by 3 years, they're pretty much looking like people who didn't go to treatment. So by 3 years post-treatment, most people have relapsed, and that's, we think, a large proportion of that is about how the brain is affected by methamphetamine. And in fact, some of the outcome studies have shown that people who use meth, who go into treatment, do very, very well in treatment. So treatment's really effective. In fact, one study recently, in the last couple of years, an outcome study showed that people who use methamphetamine actually do the best in treatment out of all drug users. So treatment does work. It's just that post-treatment period that's a problem because of the brain effects on the meth. And just so you don't think this is particularly about residential rehab, Amanda Baker and I did a study quite a few years ago now, and we published it in 2005, so it's 15 years old at least. And in that study, we just gave people 2 sessions of motivational interviewing and CBT, or 4 sessions of MI and CBT, and the 2 sessions and the 4 sessions increased abstinence significantly compared to a control group that just got a self-help booklet. But you can see we only measured at 6 months, the relapse at 6 months, but you can see it's bang on that residential rehab line. And this is the study that showed that people who use meth do the best in treatment out of all drug users. And you can see that that's pretty much bang on as well at 74% at 1 year. So basically what that tells us is because of some of these brain effects, people do very well in treatment, and it doesn't matter what treatment they get, they seem to do well whatever treatment they get, but then they also seem to relapse at the same rate post-treatment if they don't have that extra support after treatment. All right. The other really significant effect of methamphetamine on the brain directly relates to the level of mental health problems among people who use meth. And I'm sure you've heard that people who use meth have high rates of mental health problems, and that's absolutely true. So around 25% of people who use more than once a month will have experienced some type of psychotic symptom while they've been using. So 25% is a lot higher than the general population rate, obviously. And we think that is related to the levels of dopamine in the brain. So high levels of dopamine have been associated with psychosis and psychotic disorders. And so we think that in people who are vulnerable, the level of dopamine increases the risk of psychotic symptoms. And then a very small number of people of that group go on to having an enduring mental health issue or mental illness like schizophrenia. But quite a large proportion of them will have temporary drug-induced psychotic symptoms. But by far the biggest mental health problem among people who use meth is depression, with 80% of people actually meeting criteria for some type of depression. So around, one study showed that around 40% of people who use methamphetamine meet criteria for major depression, as outlined in the DSM, and then another 44% meet the criteria for drug-induced depression, based on DSM criteria again. So, more than 80% of people will have significant depression at some point while they're using. And the other thing that is relevant here in mental health problems is level of aggression and anger among people who use methamphetamine. And as I said before, the increase in noradrenaline is probably partly contributing, and also the damage to the dopamine system and the emotion regulation system will be contributing as well. So we think around, again, about 25% of people might feel angry or aggressive at some point while they're using meth. But the number of people who actually commit aggressive or violent acts while they're on meth is higher than the general population, but is not significant, is relatively small still. And the people who are most likely to become aggressive is people who have been aggressive or violent in the past. So it tends to be people who are already have that antisocial tendency. So when they're on meth, that just gets amplified. But if they're using multiple drugs at the same time, if they're highly intoxicated and their emotion regulation system isn't intact, that increases the risk of anger and aggression. If they're withdrawing or coming down, that's a real trigger for anger and aggression. And, you know, I'm sure you know yourself, if you haven't been eating or sleeping for a while and you're feeling like crap, it's easy to get a bit snappy. So if you're already that way inclined, that might amplify that issue. If they've got multiple difficulties in their life, they're much more likely to have an increase in anger and aggression. So things like financial problems and legal problems and other health problems, housing, relationships. And of course, all of those things are exacerbated by and can cause linked with using methamphetamine and other drugs as well. And a fair size of the aggression and anger is also related to some of those psychotic symptoms. So what we've got then is, in terms of people who use meth at the lighter end, there's still some significant effects on the brain and body that can affect functioning, all the way up to someone who's using very regularly, daily even, and is dependent on it. They have some additional effects on the brain and the body of longer term use. So that's really all I had to say. I just wanted to, for the moment, wanted to alert you, for those of you who are in Victoria, I'll just do a quick little ad. The Department of Health have funded us and some other providers to provide training for frontline workers on ICE. So that's all those settings you can see there, from alcohol and drug workers to transport workers and everyone in between. So if you're interested in finding out more and going to one of these half-day workshops, our website actually is the best place to go, which is 360edge.com.au. And also, if you, I'll take questions now, of course, but if you have any follow-up, you can find me in any of these modern ways. Thanks very much.
Fantastic. Thank you, Nicole. That was extremely informative. We've had some questions flowing in, but I'd encourage everybody now to type in your questions for Nicole in your questions box that you have there. So a lot to think about, and the information's resonated with a lot of people that we have here today relating to what you've been saying. We've had a few questions come through, a couple I think you've touched on already, asking about the long-term cognitive effects on the brain from heavy use, particularly over years of time, so 2 to 5 years, and asking whether these can be reversed. And I think the message you gave was that they can, but if there's anything more to add to that?
Yeah, as far as we know, most of those effects are recoverable over time. Most of the effects are recoverable over the first 1 to 2 years, which is significantly longer than other drugs. So, for example, the research around alcohol and cannabis show that most of the significant effects on the brain while someone's using, aside from the permanent damage that alcohol does, some of those effects are reversed in the first few months. So it's a long period of time. People are waiting until they feel better and their brain's functioning again. But there is some emerging evidence that people who use a lot of meth when they're younger have a much higher risk of Parkinson's when they're older, and so there must be some permanent damage. But we think that in terms of functioning, the damage is recoverable over time.
Excellent. And we've had another question come in here, and you touched on this in your presentation about needing to put in place more supports for people after going through a residential rehab program and those high relapse rates that you showed today. And if you had any ideas about the kinds of supports or extra measures that could be put in place to better support people coming out of rehabilitation programs to help prevent relapse.
Yeah, there's not really much in the research to guide us on this, but the study that I mentioned that looked at outcomes, just overall outcomes across Australia, that showed that meth users do the best in treatment, they also found that for all people who use drugs who are in treatment, but particularly for people who use meth, if they're engaged in some kind of post-treatment therapeutic activity like a mutual aid group or support group like Smart Recovery, or have some peer support around them, and that can be really helpful in preventing relapse. I tell clinicians just to give them a call every now and then, maybe once a month, and just check in and see how they're going, because the idea really is what we want to do is to catch people before they relapse. And so if they're saying to you, if you just give them a call and they're saying, gosh, I'm really craving all the time now, then you might be able to say, well, just come in for a booster and we'll have a chat and top them up a little bit to help them along. But really any type of post-treatment support will probably be helpful. Any kind of functional type post-treatment support will be helpful. So family, peers, groups, just a phone call every now and then. Engagement in activities in the community, exercise, anything like that, I think would be pretty helpful for them.
Yeah, definitely. And somebody has asked if there are any treatments that we know of that have lower rates of relapse compared to other treatments. Are there differences in the types of treatments that people receive and rates of relapse that we know about?
It doesn't really seem to be the case. We've just actually finished a meta-analysis of treatment for people who use methamphetamine, which is not published yet, so I have to be a secret squirrel about it. But the study that Amanda Baker and I, the manual that Amanda Baker and I developed around the 2-session intervention, that actually seems to come out as one of the better treatments in terms of abstinence and stopping use. But then without those post-treatment supports, everybody seems to roughly relapse at about the same rate. So there are treatments that are more effective, and in fact 2 sessions is pretty good, that you only need to do 2 sessions and you get the same kind of effects as going into resi rehab or day rehab or having intensive counselling. So pretty much anything is effective, and really people relapse at a similar rate.
Yep, great. And following on from that, someone specifically asked about NA, or Narcotics Anonymous, as a potentially effective support mechanism. Is there evidence for groups like this being supportive after treatment?
Yeah, we don't know too much about specifics about different types of groups, and anybody that has been to one of those groups knows that, or some of those groups knows that they're pretty variable in their support. So the study that I was referring to, the outcome study, did show that any kind of mutual aid support post-treatment is helpful. My advice is to try out a few and see which kind of resonate, because the one that's going to be effective is the one that you like the most, really. Yes,
it really has to resonate for you, and you've got to connect with that treatment. Good advice. Yeah. And a couple of related questions. Somebody's asked about the effects on the brain for young people and adolescents, if we know that there's any different effects for that population. And following on from that, a question's come in mentioning They've said for men, but perhaps particularly talking about the brain and developmental pathways shutting off at 27, and it could take a long time to reverse any damage that's occurred before that age. Is there any evidence around young people and effects on the brain?
Yeah, there's not a lot of specific evidence for the effects on young people, but so the first thing is that there's, in terms of other drugs, more generally, we know that those drugs, the earlier that you use, the more disruption you have to your brain systems. But also no one's kind of taken someone who uses meth, it's not taken a baby and then, tracked them all the way through using meth and then post using meth to see whether it's actually a pre-morbid kind of condition in the brain or it's as a result of meth. So it's a little bit messy to untangle that. But I'd have to say, just as a clinician and knowing the little that I do about the brain, that you would have to think that while your brain's developing, that putting chemicals into it that affect it so strongly is going to have some level of effect, some permanent effect. But we also know on the flip side of that our brains are really, really malleable, that they can change over time even when we're a lot older. So it's likely that even if there's some significant deficits, that they can be at least compensated for, if not recovered, over time with some specific kind of intervention.
Yeah, great. And another question's popped up here about the stigma associated with methamphetamine, particularly crystal methamphetamine, and any advice for service providers and how we could better tackle the stigma to encourage people to seek help and perhaps return for help and stay connected when there is a lot of stigma around this particular drug.
Yeah, that's such a huge problem, and there's even been, I know, government ads and things that are really contributing to the stigma, which is a huge problem. And most people in the community only really get their information about alcohol and drugs from the media and from mass media campaigns. So what they're seeing in the media is very one-sided. It really focuses on the very, very pointy end of people at the very severe end. And so their perceptions and therefore their stereotypes are affected, and therefore stigma is increased. So as practitioners, I think that we can be mindful, I guess, of the language that we're using. And I slip up all the time as well, but I try and use the phrase people who use methamphetamine rather than meth users. There's some people who prefer not to use the street terms ice and meth and speed. I do tend to do that, but that may, because ice has such a bad name, it might, that may contribute. So some of it, that we can affect is about our language. We can certainly be mindful of being super empathetic when, you can see the effects on the brain. People might be affected in terms of how they engage in treatment, and it's not because they don't want to be there, it's not because they're not motivated, it's because the effects on the brain are preventing them from getting themselves organised enough to be engaged. And so we might need to try extra hard to help people stay in treatment and give them a really good treatment experience. I think that's really important. And I think we should call it out if we see stigma in the community. There's a group called AOD Media Watch that's just started last year that is kind of like Media Watch on ABC. And if you see something in the media that you think is really appalling and increases stigma, you can write to AOD Media Watch and either write an article or alert them to that, and they will publish articles critiquing media on their stigmatising language and other things like that.
Yeah, so there's a role that we can all play in helping to reduce stigma. You also mentioned in your presentation that the dopamine takes a long time to is depleted over the long term and takes more than a year to recover. And somebody's asked whether this is true for the other two neurotransmitters that you mentioned and what we might know about these systems recovering.
Yeah, the effects on the other two systems are not as great as on the dopamine system, and so the on the flip side, the negative effects are not as great as well. And there's not as much research around noradrenaline and serotonin either, so it's a bit hard to say in comparison. The biggest impacts are definitely around the dopamine system, and that's the system that affects some of the functioning that we see when we see someone in treatment.
Yeah, and questions come through here asking if we know anything about synthetic dopamine, whether there's synthetic dopamine available for people who are using ice to combat this kind of depletion. I'm not aware of that myself. Are you aware of anything like that, Nicole?
Not particularly synthetic dopamine, but some of the medications that have been trialled as pharmacotherapy for methamphetamine are dopamine increasing medications, and those have virtually no effect on people who use meth in terms of relapse prevention or getting them off the drug. So I'm going to guess that even synthetic dopamine might not help. One of the reasons might be because the actual structures are damaged as well. So even if you did have loads of dopamine, transporting it around the brain is not possible until those structures have recovered themselves, and that takes time as well.
Yeah, sure. And that might also lead on to another question asking if there's any additional risks for people who use meth who might also be taking antidepressant medications or other medications elevating their neurotransmitter systems.
Yeah, so there's definitely a risk of people who use particularly SSRIs but other antidepressant medications that increase serotonin. There's a risk of serotonin syndrome because meth also increases serotonin, and so you get a bit of a double dose of it. So we do recommend people don't use antidepressants within 2 weeks of having used methamphetamine because it can increase that serotonin problem.
Okay, great. There's a few questions that have come in about the use of methamphetamine or crystal methamphetamine in pregnancy. How might we better support these women? And if we know of any effects on the unborn baby of a regular mother who might be using methamphetamines?
Yes. Okay, so we don't know very much about that. And most of the effects of meth in pregnancy are around the effects on the mother and the placenta. So there's a high rate of placental abruption, miscarriage, early birth and premature birth and stillborn birth among people who use meth. But these tend to be people who are using very regularly. A lot of people just stop if you remind them to stop, just like smoking, but there is a small proportion who will continue to use, and the risk is in losing the pregnancy. We don't have much of a sense of what happens to the baby afterwards, but you'd have to think that it would affect the baby in some way, that they don't seem to be particularly affected by withdrawal when they come out, like in the same way that people who use heroin, their babies often go into significant withdrawal once they're born. But also on top of that, people who are using so regularly and have trouble stopping, they've probably been using for a long time, they're heavily dependent, and they've probably got a whole range of other things that contribute to those problems, like being underweight, not being well nourished, not doing any exercise. So all of those things also contribute to the problems, and we haven't really been able to untangle those. So there is significant problems. We do advise people not to use meth or any other drugs while they're pregnant, but for those who can't, we just need to try to reduce the harms. We might be, for example, doing more prenatal checks on people to make sure the baby's okay. If people can reduce their use, that's going to be better than nothing. And so there's if we can't ask, if people are having trouble stopping, we don't really have other mechanisms to help them stop. But if they can reduce their use, then that's helpful. And if we can reduce harms in some way, that's helpful as well.
Great. Thank you. We've had a fantastic discussion session, and we still have many more questions than we have time to answer. We did have a few come in asking whether the slides and recording is going to be available after the webinar, and we will certainly be uploading both to the Cracks in the Ice website. So I'll send out an email in the coming week with a link so that you can access all of those slides and go over the fantastic information that Nicole's presented us with today. So I'd like to give a big thank you to Nicole for running us through a fascinating topic. I think everybody's learned a lot and have taken away a lot of practical implications for their work and in their life. So thank you, Nicole. Thank you very much, everybody, for joining us. We will have another webinar coming up in March, which will be focusing specifically on stigma and having the presenter Jack Nagel talking about his personal experience and particularly how we can reduce stigma for young people and encourage help seeking. So please stay tuned and join us then. Have a wonderful day, and thank you very much, Nicole.
Thanks, Louise. Thanks, everyone.
Thank you. Bye-bye.